क्या तो रहा आपका वीडियो आ रहा है वीडियो आपको? अब खोलो उसको, मेरा वीडियो नहीं आ रहा, वो कैमरे वजह से प्रॉब्लम है।
नदीम, अभी तो वीडियो भी नहीं आ रहा है मेरा।
आपका वीडियो नहीं आ रहा है मैम, मैं आपको देख नहीं पा रहा हूँ, आपका साउंड एकदम साफ आ रहा है। आपका कैमरा वो नहीं चल रहा है, इसलिए वीडियो नहीं आ रहा है।
डेस्कटॉप पे कैमरा तो आ रहा है।
हाँ, डेस्कटॉप पे आ रहा है। डेस्कटॉप पे तो आपको आना चाहिए वो आइकॉन प्रेजेंट नाउ वाला। आ रहा है आपका प्रेजेंट नाउ वाला आइकॉन?
सॉरी सॉरी,
प्रेजेंट नाउ वाला आइकॉन आ रहा है मैम डेस्कटॉप पे?
नहीं, नो।
गूगल मीट आपने वो लिंक में क्लिक करने से वो आ जाता है, वो पेज खुल जाता है।
I'm able to join. The audio is okay.
ये ऑडियो इज ओके मैम, बहुत साफ सुनाई दे रहा। आपका वीडियो नहीं आ रहा है। आपको लैपटॉप में वो प्रेजेंट नाउ वाला आइकॉन आ रहा है?
नहीं,
नहीं आ रहा राइट साइड में स्क्रीन पे?
those three dots or something.
जस्ट डॉट के पहले।
Like on your screen,
यस मैम।
on the right top, I'm
नो
able to
टॉप
see.
नहीं, बॉटम, राइट
Bottom,
बॉटम।
there's nothing on the bottom.
देयर इज ऑडियो का आइकॉन, एक वीडियो का आइकॉन, और उसके राइट साइड में एक प्रेजेंट नाउ का आइकॉन।
ये मीटिंग डिटेल्स हैं, शो एवरीवन, चैट, एक्टिव। वो तो स्क्रीन के बाहर है।
नहीं, स्क्रीन में ही प्रेजेंट नाउ आना चाहिए।
प्रेजेंट नाउ, हाँ नीचे है ये तो।
हाँ, वो नीचे जो है उसको क्लिक करिए
हाँ,
मैम,
हाँ,
आपको योर एंटायर स्क्रीन आएगा।
ओके।
आपका ये चीज लैप उसमें आ रहा है, डेस्कटॉप पे आ रहा था?
ये इस पे आ रहा है, लैपटॉप पे।
डेस्कटॉप पे नहीं आ रहा है वो चीज?
डेस्कटॉप पे देखती हूँ।
एक बार देखिए, तो वहां से आपका ऑडियो वीडियो दोनों चल रहा था। इस पे आ रहा है आपके डेस्कटॉप पे? आपका मैम, आपका ऑडियो बंद है, माइक बंद है मैम, अपना माइक अनम्यूट करिए। मैम आपका माइक ऑफ है.
Okay, now it's okay. No, it's fine. Yes. And now, ऑडियो अभी हो रहा, अभी वीडियो ही बंद हो रहा, इस पे शेयर नहीं हो रहा ये. प्रॉब्लम से आपने एक ईमेल आईडी से एक्सेस किया ना, तभी वो आ रही है. अच्छा, ये पर ये शेयर नहीं हो रहा अभी. ये कौन सा गूगल मीट है? हाँ, यहाँ पे होती है ऑप्शन शेयर की, वो 3 बटन.
Present now. Look at the option present now.
वाइट बोर्डिंग कोलैबोरेटिव प्लेटफॉर्म्स हैं. ये वाला बटन, ये वाला बटन इंटायर स्क्रीन पे क्लिक कीजिए. अब स्क्रीन पे क्लिक कीजिए. अच्छा, शेयर. ओके, आई थिंक अब मिनिमाइज करो, आपकी स्क्रीन शेयर हो रही है.
Yeah. Screen share हो रही. Fine, very good.
Now minimize it.
Now is it okay? Just go to your PowerPoint.
स्क्रीन शेयर बड़ी कर दीजिए.
Yeah. Full screen कर दीजिए.
Yes.
Yeah, just press that hide. Press that hide thing.
Is it okay now?
Yeah, ma'am, just press that hide thing so that that pop-up will go away.
Okay.
Right. Now, is it okay? Comfortable?
Yes.
Right. So, should I start?
Yes.
So, fair enough.
Shall I be able to see myself?
You won't be able to see yourself. The only way you can see yourself is that you have to log in with another device and put the audio off of that device.
No, it's okay then. It's all
We
right.
can see you clearly.
Fine.
Should we start, ma'am?
Yes.
Should we start?
Yes, we should.
Right. Good evening, everybody. Welcome to this evening episode of Pursue. And today is the first lecture in the Hematology series, which is the evolving science of hematopathology. Yesterday, today, and tomorrow. We have two very eminent hematologists here. I would like to introduce the moderator, and moderator sir will introduce the speaker. So the moderator is Professor Dr. Bakul Dalal sir. He is an MD, FRCA, BP, FACP, FASCP, a clinical professor, UBC Faculty of Medicine, Department of Pathology and Laboratory Medicine, Vancouver, Canada. I would request, sir, please, would you introduce madam, and we'll start from there.
Hello everyone. Good morning from me and good evening for you. I am delighted to introduce a very dear friend of mine, Professor Dr. Neelam Varma, MD, MNAMS. She is the ex-professor recently retired as head of hematology at Chandigarh. Dr. Varma hails from the mountains of Himalayas. She did her MBBS from Shimla and she did her MD from PGI Chandigarh, where she decided to settle and make a career out of it. She further trained in Australia and England, and then she settled down in Chandigarh to write papers and run the department. She has written over 350 papers and written 23 chapters. Very prolific writer indeed. Her main interests are in clonal hematopoietic disorders like leukemia, aplastic anemia, myelodysplastic syndromes, PNH, etc. And she has given multiple lectures in all over the world, including the Dr. Malti Sathe oration in 2014. She is the past president of the Indian Society of Hematology and Blood Transfusion. She'll talk today about her lifetime as the experience of hematopathology during her vast career, yesterday, today, and she'll gaze into the crystal ball to tell her what tomorrow is bringing to us. Dr. Neelam Varma, please.
Thank you, Dr. Bakul, for this endearing introduction. I wish to say that this presentation is not an exhaustive account of all the milestones in the evolution of hematology, hematopathology, and there are no relevant conflicts of interest to disclose. So the field of hematology has evolved so much, but apparently my computer and its connections haven't. So very sorry for the delay. The discipline of hematology has given me so much. It has allowed me to learn from my mentors, from my peers, from my students, from my colleagues, and allowed me to travel the world and make friends like Dr. Bakul Dalal. I am really blessed. I just want to draw your attention to this picture. I wonder how many of you can identify this item. This is a source of light. It has a diya inside and it looks like a designer antique item kind of a thing. But I remember back in mountains where I come from, in 1960s, I think we were using these kind of lanterns as source of light. Only difference was that instead of this metallic chimney, our lanterns had those glass chimneys, and it was really some effort to keep them going and keep them clean. And it seems these are coming at a good price these days. Those earlier ones used to be very cheap. And now we have these different sources of light, and you have different shapes and sizes, give you a lot of illumination when the sunlight is not around. So same way things have evolved in the field of hematology too. I don't know how many of the younger people are really aware of the Newbar chamber, the hemocytometer chamber, but I remember using these in 80s and 90s also, and when the automation came, the hematology analyzer, the hemocytometer fell by the wayside. So that's what life is all about. Things improve and you move on to the better things. Thomas Jefferson, the third president of USA, famously said, "I like the dreams of the future better than the history of the past." But today we are in for a lot of information about the past, the history, the evolving science of hematopathology. So I'll devote a lot of time on the yesterday part of it, little bit of today, and as Dr. Bakul said, I would gaze into future, something about tomorrow, how things are likely to happen. And then in between, I'll talk a little bit about the Indian scenario and give you some examples from the department, how things evolved. But that would be touching just few aspects of hematology, because I know this lecture is going to be followed by specific lectures on different aspects of hematology. So we know that blood occupies a central part of the human psyche. It is essential for life and as a source of the life force itself. Every civilization possesses records which chart the human fascination with blood and bloodletting in terms of both ritual and medicine. The study of blood and hematology is regarded as a broad and evolving field of medicine and has fascinated physicians and scientists throughout the ages. There are some very eminent people, keen observers, with very dedicated approach to their field of interest. People like Anthony von Leeuwenhoek, William Hewson, Rudolf Virchow. You'll get to hear these names again in my presentation. So they really laid the foundation on which the entire discipline of hematology has been built. So if you ask me when did hematology as a specialty begin, the answer would be it was in the middle of the 19th century, as it required the development of the microscope and good staining techniques. That's how we could see the cells. So because seeing is believing, that's a 17th century proverb. The hematology evolved differently in different countries, sometimes from internal medicine and sometimes from pathology. So I'll be mostly using hematology and hematopathology interchangeably, but I won't be talking too much about the therapeutic or the clinical hematology per se. So because the blood cells can be obtained so readily, you just do a simple venipuncture and you get the sample. So that's why hematology has been at the forefront of technological developments throughout the centuries or since the venipuncture started. The diagnosis of malignant and benign hematological disorders has become more exact because of these technological advances. Our understanding of the pathogenesis of many diseases has also improved. All technologies and tests need to be cautiously interpreted, and a full history and physical examination should always be the first step in the investigation of patients. And bare minimum in the hematological investigation would be a good blood count, complete blood count, and a very careful examination of the peripheral blood smear and the bone marrow smears or whatever material you have. Because blood is being examined by different disciplines, so hematology evolved over a period of time along with disciplines like clinical pathology, laboratory medicine, blood banking, transfusion, nuclear medicine, oncology, medical genetics, developmental disorders, clinical chemistry, microbiology, and so on. So all these disciplines go hand in hand. So the blood turned 70 years old in 2015, the Blood Journal. So this provided an opportunity to Mr. or Dr. Barry S. Scholar to write a review about the extraordinary contributions of Blood Journal to medical science, medical diagnosis, treatment and prevention, and the evolution of the discipline of hematology. The brainchild of the hard-driving and visionary medical book publisher Henry M. Stratton and the eminence Grace Dr. William Damschek became the first English language hematology periodical, and the publication began in January 1st, 1946. So that was a landmark. The American Society of Hematology was created 11 years later. Mr. Stratton also initiated the Informal Blood Club at the 1954 Atlantic City meeting of the Association of American Physicians, the American Society for Clinical Investigation, and the American Federation for Clinical Research. He also brought together 10 hematologists at the 1956 meeting of the International Society of Hematology in Boston that led to the creation of ASH. At its organizational meeting, which was led by Dr. Damschek on April 7, 1957 at the Harvard Club in Boston. The first official ASH meeting was held in Atlantic City on April 26, 27th, the year 1958. So interesting thing is that Dr. Winthrop set up the International Society of Hematology in 1946 and the American Society of Hematology in 1958. But he initially opposed the setting up of hematology as a separate specialty, believing it should remain under the umbrella of internal medicine. He, however, appears to have changed his mind when he was elected president of the International Society of Hematology and later president of ASH in 1971. So those things also happen. So what happened in France? Hematology as a specialty began in France in 1931, followed by Italy in 1935, Germany in 19, and Netherlands in 1953. The French Society of Hematology was the first in the world to start in 1931 by Paul Chevalier and John Bernard was the General Secretary for, can you believe it, for almost 40 years. So you get a position of eminence and you hold on to it, it happens. Unlike in Britain and the United States, no opposition to the establishment of a French Hematology Society. In UK, the society representing British hematologists came rather late to the scene. British hematologists had traditionally presented papers at other societies like Association of Clinical Pathologists, the Association of Physicians, and the Pathological Society. Formation of National Society for Hematology was opposed by many in Britain. They shared the same concerns as Dr. Ventrovitz. The British Society for Hematology was formed in now, British Society of Hematology, single most important voice of this specialty in UK. It has been very successful financially and has one of the leading journals, the British Journal of Hematology, and website BloodMed, which are very popular. In Germany, the German National Society of Hematology was founded in 1937. And then the transfusion medicine, hemostasis, thrombosis, they were originally all considered part of hematology. But later the blood transfusion separated, and then still later, the thrombosis and hemostasis part also separated. Then in 1977, the society became the German Society for Hematology and Medical Oncology, and so on. In Russia, the he was a Russian-born morphologist working in Chicago, and in 1924 he used extensive histological findings to identify a singular type of precursor cell within mesenchyme that develops into different types of blood cells, so-called mesenchymal stem cells. So which was a landmark discovery. Expanded on this finding, and then the first clinical trials of mesenchymal stem cells were completed in 1995. 15 patients were injected with cultured mesenchymal stem cells to test the safety of the treatment, and then various clinical trials were being conducted to evaluate the efficacy of mesenchymal stem cells in treatment of GVHD following the allogenic stem cell transplantation. Hematology in Russia developed as an interest in the treatment of hematological malignancies, but later became intimately involved with transfusion medicine because of the needs of the world wars. The International Society on Thrombosis and Hemostasis, the International Committee on Thrombosis and Hemostasis was formed in 1954, and the International Society on Thrombosis and Hemostasis came into being in 1969, and it has expanded its areas of interest to platelet function, regulation, mechanisms of thrombosis, fibrinolysis, thrombolysis, problems of thromboembolic disorders, and so on. Then International Society of Blood Transfusion also was formed, and the impetus was given by two major fields or areas, the world wars and the infectious diseases. Although the casualties were massive in World War I, it was not until the Spanish Civil War that modern blood transfusion came of age. So that's how the need for blood collection, improvement in the blood collection, typing and transfusion was felt, and a lot of advancements happened into it. And with the advent of HIV/AIDS also, this became an issue, and the screening for the various viruses became mandatory. In Europe, the European Association of Hematology was founded in Brussels, Belgium in June 1992. EHA has close ties to the European School of Hematology and the ASH, and engages in education both within Europe and many other countries through its excellent outreach programs. The birth of EHA, however, was not without its difficulties. The EHA currently holds in the month of June, and the journal is Hematologica. So this again I have taken from the review article from Blood, and it gives you the various milestones in the history of hematology before 1946, and you just marvel at the capacity of fine observation of these stalwarts, and the sense of dedication and the keenness to work with minimum facilities at their disposal. So there you have the discovery of closed circulation by Harvey, have Dutch biologist Jan Swarmer Dam, who discovered RBCs using a primitive microscope. Just simple lenses were used and they could magnify the items many times, up to 200 times, and they made such fantastic discoveries. Description of not really RBCs, but I think these were insects and sperms and small plants by Anthony van Leeuwenhoek in 1670. The discovery of WBCs, fibrinogen, and so on in 1770 to 74. Came the transfusion of human blood to a patient in 1818, the description of Hodgkin disease, the first successful whole blood transfusion to treat hemophilia by Lane, the hemocytometer development happened in the year 1852 to 76, and this was the effort of many investigators. The discovery of the rose by Newman and independently by Bizozero. In 1868, Warsaw described leukemia, thrombosis, and embolisms, and everyone in hematology pathology is aware of the Warshaw's triad in thrombosis. The blood cell counting developed by Ehrlich, blood cell staining developed by Ehrlich. So that was something fantastic, that you could see these cells, which happened in 1878. And this was followed by his identification of three types of granulocytes: mast cells, polychromatophilia, and megaloblasts. The first description of phagocytosis by Makhnikoff in 1882. First role of platelets in hemostasis and thrombosis in 1888. The discovery of the blood groups by Landsteiner in 1901, then description of polycythemia vera by Osler in 1903, description of paroxysmal cold hemoglobinuria, the bleeding time assay and effectiveness of platelet transfusion, the sickle cell disease, the identification of those sickle-shaped RBCs, first description came in 1910, use of citrate as anticoagulant, the description of Glanzmann thrombocythemia by Glanzmann, the description of infectious mononucleosis, description of Fenelby syndrome, by Cooley and Lee, the von Willebrand disease, the classic report of liver as first effective treatment of pernicious anemia by Minnow and Murphy. Then first description of Fanconi syndrome. These are such rare diseases, but these eminent scientists had the keen eye to detect these rare things also. The description of Fanconi syndrome happened in 1927. Hematocrit technique refined by Vintrove in 1929. Sternal puncture to obtain bone marrow. And we do the bone marrow examination as a routine, most of the hematology practice. The identification of role of intrinsic factor in 1929. Vintrove described the classification of anemia based on RBC indices in 1934, and we are still making use of this information. The development of acidification assay for PNH happened in 1937, and it's such an intelligent test, really remarkable. The anti-hemophilic factor was identified in 1937, effect of warfarin on PT in humans described in 1941, macroglobulinemia described in 1944, anti-human globulin test to identify incomplete Coombs. So Coombs test in 1945, and we still cannot get away from this test. We still have to use these in the relevant scenario. Efficacy of nitrogen mustard compounds in lymphomas and all. The electronic blood cell counting came on board in 1953. After this, the advancements in blood cell counting, the CBC analyzers haven't stopped really. It's going on and on. The Journal of Clinical Chemistry and Laboratory Medicine was founded in 1963, although at that time the laboratory medicine was didn't exist as an independent discipline in 1963. It was just a stepchild of clinical chemistry discipline. All the advancement, the automation was happening in clinical chemistry, and the laboratory medicine were doing the manual techniques. They were employing the manual techniques. So, yes. So what is the role of technology? What has happened in hematology? You saw some of this history. So I am a great fan of history of science, history of hematology especially. I hope the few in the audience share my interest and can really relate to these landmark discoveries. So the most remarkable things happened: the discovery of development of microscopes and the staining methods, so that you could see these cells. The fluorescence microscope, the epifluorescence and confocal microscopes, then automated cell counting, the flow cytometry, automated digital cell morphology is just coming on board. The development of FISH probes, but most remarkable thing that has happened in 20th century is the molecular biology techniques, the PCR and its varied extension and modification that has really changed the scenario. This provides you the table of papers published in Blood between 2006 and 2015, and I just wanted you to notice that the contribution from India is just 0.1%, which is something we need to ponder on. So then we move on to the Indian scenario, what is happening and what has happened over the years in India. But before that, I'll just share these few. Dr. Ghosh has so beautifully written in the review article published in 2011. The progress in any scientific field, including hematopathology, is possible only when a country is ready for one. So are we ready for that? Number two, good work in hematology is generated, or in science is generated from a handful of centers in any country. These centers are usually directed by leading workers and pioneers in the subject. Subsequently, the able disciples trained in that center spread out elsewhere in the country, expanding the vista of research. The fruits of good work finally reach the common people, either via industry-institute cooperation or, as in case of the medical research, institutes may themselves develop new advanced facilities to help common man. So, Indian Society of Hematology is about 62 years old now, and it has split out from the Indian Association of Physicians of India Society, as happened in the ASH also. So pioneers in the field of hematology in India did some exam. They also developed Center of Excellence and Human Resources for hematology work in India. But we realized that they worked under extremely difficult and trying circumstances on our subject, not widely appreciated as an independent subject. With limited funding from Indian Council of Medical Research that was available earlier on, now we have some other sources of funding available as well, like DVT and DST and so on. So the pioneers were working. Professor J.B. Chatterjee, Dr. Das Gupta in Kolkata, pioneers working in Mumbai, working in CMC Vellore, and at the Bombay Blood Group Reference Center under the aegis of ICMR. So all they were trying to spearhead the advancement of hematology in India. National Institute of Nutrition did some pioneering work on iron metabolism and continues to produce useful work in the same area. So before 1980s, because the reagents were not freely available, automation wasn't there, so the emphasis was on studying the primary hematological disorders, interactions of nutrition deficiency and hemoglobinopathies, malaria, kala azar, microfilaria and other parasite related topics. These common things which were there in our country. The establishment of assays for folic acid and vitamin B12 was required to study these deficiencies in Indian population. The time consuming and technically demanding microbiological assays had to be established. In some of the centers, School of Tropical Medicine, AIMS, PGIMER, PARC, CMC, Vellore, National Institute of Nutrition are few such centers where such assays were available. In our department also, these assays were available, and the organisms, the Lactobacillus casei and the Greener gracilis, we were maintaining those cultures, and I think in 1992 or somewhere like that, the cultures died down, and later on we shifted to the automated assays now. The original work on vitamin B12 and folate deficiency for almost a decade originated from the Department of Hematology at our institute under the able leadership of Professor K.C. Das. He also showed contribution of folate coenzymes in the transport of vitamin B12 across the cell membrane. He devised a detailed deoxyuridine suppression test, DU suppression test, to dissect mixed B12 and folate deficiencies in a test tube and unmasking of B12 and folate deficiency at biochemical levels in the presence of severe iron deficiency. Another important classic observation was that lymphocytes remember past folate B12 deficiency long after these deficiencies were corrected. So I think some of these tests were being done when friends like Dr. Bakul Dalal and others were working in the department, or some of them must have left also to greener pastures. This is how the test was being done. I think I won't go into the details. I'll just move on to the next part of hematology evolution in Indian scenario, that in around 1980s, the myelodysplastic syndromes were being described in detail. Classification of acute leukemia by FFB criteria has been proposed. So different people, different workers were working on these areas. Immune dysfunction caused by iron deficiency anemia, B12 folate biochemistry, binding proteins of vitamin B12 in different hematological disorders, evaluation of microchromatography for measurements of HbA2 compared to visual inspection, elution, and measurement of HbA2 from electrophoresis strips. That was the usual methodologies being employed. The cytochemistry in leukemias, merit-refined biopsies in hematological disorders, these were the main areas of research in various institutes. Readily available, very little work on blood coagulation was done. 1 or 2 centers in the whole country were involved in basic coagulation work with home-made reagents. The first case of antithrombin 3 deficiency was reported from the country by Dr. Mohanty in our department. She also adapted the technique for detecting antiplatelet antibodies, and much more work was also done by her and other colleagues, hers and Dr. K.C. Das. I think because of shortage of time, I won't go into all those details. So after the 1980s, the work in the area of thrombosis and hemostasis started getting published significantly more. Allogenic and autologous marrow transplantation data started emerging from few centers. The interest in work in the area of hemoglobinopathies, nutrition anemia, as expected, slowly dwindled. HIV infection arrived in our country and transfusion-transmitted viral diseases became an important issue. So in the meanwhile, young doctors also started showing interest in hematology and the transfusion medicine. But we must realize that most of the Indian medical colleges or institutes do not have a separate department of hematology or hematopathology. Hematopathology and transfusion medicine mostly function under the umbrella of Department of Pathology. Only two institutes offer hematopathology super specialty courses, that is DM Hematopathology, that is PGIMER Chandigarh and AIMS New Delhi. Many other institutes offer clinical hematology super specialty courses, the DM clinical hematology to candidates having MD degree in internal medicine, pathology and pediatrics. This picture was taken in December 2012 during the PGI alumni meet, and this shows you the pathology alumni group. Just strain your eyes and try to identify the luminaries in the field of hematology. Professor K.C. Das, late Professor K.C. Das, Dr. Deepika Mohanty, she is there in the audience, Professor Gurjeevan Garewal, and then you have a host others, my respected teachers, colleagues and many students, many of whom have become leading figures in hematology and pathology and other allied specialities. So always nice to look at this picture. So I'll just come to a few examples which will show you that what different we are doing in different diseases over the years. This short paper was published in American Journal of Hematology 2000, and here we, I think, compared the conventional test for PNH, the HAMS and sucrolysis test, and antibodies CD55 and CD59, which I got as gifts because these were not commercially available that time. And later on, we moved on to using the commercially available reagents, the FLAIR, the anti-CD24, anti-CD15 monocytes were being tested, or all these other cell types using FLAIR, and so on according to the proposed guidelines. And so with great sensitivity we could detect the PNH clones. And this paper showed that the presence of PNH clones does not completely exclude an inherited bone marrow failure syndrome even in children, although there was an earlier publication in 2014 Hematology where Dizan et al. Reported that detection of PNH clones helps to exclude inherited bone marrow failure syndromes. We beg to differ. So the usual diagnostic workup of PNH entails preliminary tests, the screening tests, the specific test for PNH diagnosis based on the complement sensitivity and its causes. So HAMS sucrolysis test I mentioned. Then we have gel cards and then flow cytometry for GPI proteins, the FLAIR assays. Now we don't follow this routine, that we don't do the preliminary test, screening test, we just go on to perform flow cytometry for GPI anchor protein and the FLAIR assay for classical PNH cases or for detection of PNH defect and bone marrow failure syndromes in the setting of thrombosis and so on. And if we find a defect and patient is suspected to have classical PNH or bone marrow failure syndrome, then we go on to perform these other tests, the HAMS sucrolysis test. I think there have been almost years when we have HAMS and sucrolysis test, although it's nice to get them done and show to the students. So I think I'll just skip these. The way we used to do HAMS test and the sucrolysis test, it would take almost whole day for the technician to perform these tests, whereas flow cytometry gives you just perfect results. Just to show you the granulocytes, which are showing 85.7% deficient population. The granulocytes here showing 92.3% deficient population. Size showing 91.2% PNH population. The RBC is also showing a significant 53.4 and 22.5% PNH population. And this patient had overall clinical presentation, and the flow results also support or confirm a diagnosis of classical PNH. Then what is happening in CML? We know about these many first in the history of CML, in the history of hematology. So it has to be diagnosed in the appropriate clinical setting. You look at the peripheral smear, these beautifully stained, the whole range of myeloid cell populations. And then earlier we used to do so many things, the LAP scoring and whatnot. Emphasis on hypercellular bone marrow with granulocytic and granulocytic microkaryocytic hyperplasia. Now we can detect the Philadelphia chromosome, and many of you might remember that earlier the photographs of the banded metaphases were taken. Then the technician, Mr. Krishan Lal and Kiran Malik and so on, they would cut out these individual chromosomes and then line up and have a karyogram ready for you for reporting. Now the same job is done by our karyotyping station, and with much greater accuracy and sensitivity. Now we, in addition to the cytogenetics analysis, we perform the automated RQ-PCR using the Gene Expert system also for our CML patients for the monitoring purposes. We perform the RT-PCR also to identify various BCR-ABL transcripts also. So this was the publication, our experience published in 2015 about early molecular response in CML, where we had used the Gene Expert in these patients. This slide shows you a paper written by Reena, Jasmeena and Manupdesh about the hematological practice in India. Just the important message is that hematological practice ranges from availability of advanced diagnostic facilities and treatment to unavailability of basic medical services to rural India. Problems include a very huge population, the socio-economic disparity, minimal coverage of health insurance schemes, and the government's inability to provide universal health coverage. And the recent experience with COVID-19 has really the deficiency in our health coverage, the coverage of the health care in our country. This is a student of Reena, Manu Jambal, who's done a PhD thesis on the unexplained, uncharacterized hemolytic anemias also. This just shows you usage of NGS to identify nonsense variant in the hexokinase 1 gene causing severe non-spherocytic hemolytic anemia. So in the case of childhood B-cell precursor ALL, we are supposed to do the morphology, we are supposed to do the flow cytometry, and then after identifying BCT ALL, we have to perform the cytogenetics, FISH, RT-PCR in these patients, and if possible, DNA index also. So this is just example of translocation 411, and This shows you the RT-PCR multiplex RT-PCR result for VLL fusion transcripts, and the ETB6 RANX1 fusion. The probes can tell you about the fusion of these two genes, high hyperdiploidy, or the intrachromosomal amplification of chromosome 21, IAM21. So very informative probes there. And Shrijesh has spearheaded this work, and I think it just got accepted or just got published. I think just the page numbers are not there. And this is about the frequency, hematological characteristics, and end of induction residual disease in B acute lymphoblastic leukemia with BCR-ABL1 like chimeric gene fusion in a high-risk cohort from India. So we are doing almost everything that can be done for these patients. And as a part of PhD thesis, Dikshit had just finished his work on identifying BCR-ABL-like gene signature using machine learning based nomogram. So how has the science of hematopathology evolved? You had the hemocytometer earlier, and then some of the earlier hematology analyzer, and then you can have most advanced CBC analyzers available these days, which can give you so many diagnostic parameters and some research parameters which can be validated to be used as diagnostic parameters. So something like monocyte distribution width in the setting of sepsis. We have just analyzed this parameter in our emergency department patients. Can peripheral blood film be analyzed digitally? Yes, these different platforms are available. The Cellavision, the Sysmex, the ST, the Vision Hema. So if possible, if available, they can be used. And this group where Gina Zini is also one of the authors, they say that the morphological assessment of the blood smear has been performed by conventional manual microscopy for many decades. Recently, rapid progress in digital imaging and information technology has led to the development of automated methods of digital morphological analysis of blood smear. In order to realize the full potential of digital morphology hematology analyzers, pre-analytical, analytic and post-analytic parameters should be standardized. Manufacturers of new instruments should focus on improving the accuracy of cell pre-classifications and the automated recognition and classification of pathological cell types. With all current devices, a skilled morphologist remains essential for cell reclassification and diagnostic interpretation of the blood smear. So this is quite a intelligent use of the technology, but I think we are yet to use it in full flow. Then this paper was published in Acta Hematologica 2019, Morphological and Immunophenotypic Clues to the WHO Categories of Acute Myeloid Leukemia. If you look at the molecular classification of acute myeloid leukemia, we just shudder to think how many of them you can really diagnose. But if you do this morphology and immunophenotypic you take help of morphological and immunophenotypic clues, you can certainly diagnose acute promyelocytic leukemia, most of them with a high degree of certainty. Provisional identification of cases associated with translocation 821, inversion 16, translocation 122, and NPM1 mutation may also be possible. And so is the case with transient abnormal myelopoiesis of Diamond syndrome. How I wish that this statement, these clues are available for other categories of AMLs also. Advances in flow instrumentation. These are new image flow cytometry and mass cytometry. The single cell sequencing, which is going to come up in a big way, I think, in near future. And there are many applications which can be there, but I think assessment of response to therapy, vaccine development, cell cataloging and cell atlasing, making atlases of cells. These are some of the uses. And then if you look at the top of the list, biomarker discovery, rare cell type discovery, which is very much feasible with the single cell genomics. There are many other applications also. So evolving science of hematology tomorrow will be that there is increasing participation of basic biological scientists and scientists from various physical sciences and information technology to solve some of the vaccine problems of some of the hematological disorders. So in near future, I think NGS will become a commonplace technology. It will become much easier to apply and should become more cost effective, I guess. And then other newer molecular technologies also should be easily. And with the use of these technologies, the disorders with germline predisposition, I think their incidence is going to go up. Right now, I think we are missing many of those. So there is a monoclonal antibody boom, there is availability of better and better molecular tools, there is explosion of knowledge on the wonders of genetics and molecular biology. So the question is, should hematologists put the microscopes on eBay? The question is asked by Mars Van Beer and Torsten Haferlack. So what is your answer? My answer is no. For the time being, we still need the microscopes. So many of the government medical institutes have not done well as expected due to poor funding, lack of incenting, and lack of a roadmap for developing and retaining human resources in our country. So there is a need for substantial inputs to improve health infrastructure and encourage real science, not pseudoscience. Thank you. Then only we'll have more developments in the field of science, including hematopathology. Thank you very much for your patient hearing.
Dr. Varma, for an informative, a very interesting and exhaustive journey through the hematopathology and clinical hematology. And we are indeed delighted to learn that hematology in India is now growing by leaps and bounds, and there are more centers for doing DM in both clinical hematology and hematopathology. When I was in India in the 70s, there was not even MD in hematology, and now you have DM in hematology and hematopathology. So we have really done reasonably well in the field of hematology. The subject is now open for discussion. Anyone, any comments?
Requesting people to unmute their mic and, speak.
By the
Yes.
Deepak night.
Hello.
Very nice talk, ma'am. You went through the past, present, and the future.
Put your video on as well, sir.
Your video, Deepak?
Yes, yes. I'll just put my video on.
Yeah.
Yes.
Good to see you.
Thank you. Thank you. I was just in another meeting by Professor Tejinder. He was giving a talk.
Right.
He just switched to this side. What I'm saying that the technology is moving at such a rapid pace. For an under-risk, it is very difficult to keep pace with it.
Yes.
So today you buy something and in another couple of months that gadget becomes obsolete and something else comes up. Today we have neck sick, tomorrow you have high sick, then you have some other sick. So there is no end to acquiring this gadget. So I think we have to make a judicious mix of technology and our own, Madam had said, microscope will still remain the bread and butter. But I think keep pace with the international technology, we have to have something minimum to basic diagnostics in a country like India. And there will be certain centers of excellence like PGIMER, Tata Memorial and NIH, the National Institute of Hematology. So like that, CMC or even we are doing reasonably well. So I think there will be some centers who will be helping people to do such high-end things. But I think most of the Indian centers would at least be able to do basic hematology work for patients.
Yes.
Good hematology with flow cytometry should be good enough to diagnose acute leukemia. And if you want to do cytogenetics and molecular genetics, I think you need to outsource rather than try to invest crores of rupees in developing these collectively. We have to develop a system of referral as to where you can send your sample for these advancements.
Yes, I would agree totally with you, Deepak. And I think in a resource constrained country like ours, we need to identify different areas, different fields of interest for different centers, I think. All the centers need not do everything, right? So some centers can have expertise in different set of diseases. Other centers can develop expertise in different set of diseases. I think that's how we can optimize our resources and produce good work. These days, without molecular biology analysis, it's very difficult to publish things, publish papers. So we need to work on that. Well, what do you think, Dr. Bakul? Should we do
Yes,
everything?
I think in the era of resource poorness, we have to rationalize the funding and develop a system whereby different large institutions will focus on different aspects of newer technology, and the referral system can be developed by everyone can benefit and still keep up to date. In a large country such as India, it is very difficult to do everything by everybody, and centers like TMC and PGI and AIMS should take leadership and develop a consortium where the advanced investigations, which are very expensive and very can be diversified.
Yes, and we definitely need more funding in the healthcare system.
There's the definite need for more funding, and
Yes.
I strongly advocate for the Medical Council of India and the Department of Health, Ministry of Health, to give more funding for the betterment of the patients, better treatment. Even though Dr. Deepak said that morphology and flow cytometry is enough for leukemias, with the newer targeted treatments, the molecular studies are becoming of important and mandatory for the proper treatment, and for that you need more resources.
Yes, for prognostication and directed treatment. Sure.
Right. Okay.
Any other comments, questions? Nobody has anybody typed? No.
No, ma'am, there are no typed comments.
Right. Okay.
Okay, Nadeem.
I think I can't expect many questions in the history part of hematology. It's just like storytelling, I guess.
The seniors are here, they should be, putting in there. I was expecting Dr. Mohanty to say something.
Is she still
She just left.
She is logged off.
Yes. Okay.
Okay.
Right.
Well, if there are no more questions, then thank you very much, Dr. Varma, for a very lucid presentation, and look forward to seeing more from you.
Thank you very much for being there, and thank you, Nadeem, for inviting me to deliver.
It is on the screen virtually. He looks like the admiral of the fleet.
Who? Sorry?
I said Bakulbai is looking like admiral of the
Yes,
fleet.
yes. He's dressed
Yeah.
up like a moderator, distinguished
Mhm.
moderator. Yes. Yeah. Good to see you all. Yeah.
Good to see you all.
Thank you very much.
Yes.
Thank you.
Thank
Bye.
you.
Right.
Thank you
Thank you
so
very
much,
much.
ma'am. Thank you for consenting,
Bye.
and thank you,
Thank
Dr.
you.
Bakul, to consent to be here as a moderator. Thank you, Dr. Deepak, and everybody else who joined in. This is a very important lecture, there in the YouTube, and there's a recorded version for everybody to go back and see the yesteryears of hematology. That is something which we all are not very much aware of. Thank you so much, ma'am. Thank you. Bye-bye. Take care, ma'am. Good night.
Thank you.
Okay,
Take care.
bye-bye.
Thank you.
Bye.
Bye-bye.
Hindi.
Thank you. Bye.
Thank you.